Continent ileal urinary reservoir. The most common continent urinary diversion is the Indiana pouch, created for the patient whose bladder is removed or no longer functions. The Indiana pouch uses a segment of the ileum and cecum to form the reservoir for urine. The ureters are tunneled through the muscular bands of the intestinal pouch and anastomosed. The reservoir is made continent by narrowing the efferent portion of the ileum and sewing the terminal ileum to the subcutaneous tissue, forming a continent stoma flush with the skin. The pouch is sewn to the anterior abdominal wall around a cecostomy tube. Urine collects in the pouch until a catheter is inserted and the urine is drained. The pouch must be drained at regular intervals by a catheter to prevent absorption of metabolic waste products from the urine, reflux of urine to the ureters, and UTI. The purpose of this procedure, the continent urinary diversion is constructed to replace a diseased or defective bladder system. It involves constructing a reservoir for urine storage internally and permits emptying of the reservoir at convenient intervals by self-catheterization of a continent stoma. Its indications: physically able to withstand lengthy surgery, greater than 1 year life expectancy, serum creatinine of less than 2.5 milligram per deciliter, gross and fine motor coordination, willing and able to participate in self-care. As for its contraindications, significant bowel resection with malabsorption of chronic diarrhea, irritable bowel syndrome, ulcerative colitis, extensive diverticular disease, bowel cancer, neuropathic bowel syndromes, progressive neurologic disorders, gross obesity, pelvic radiation, unable to comply with the following follow-up care or treatment. And for the potential complications: incontinence, difficult catheterization, urinary reflux, anastomotic leaks, pyelonephritis, obstruction, bacteriuria, urolithiasis, electrolyte imbalances, absorptive problems, rupture of the reservoir. The advantages of an Indiana pouch as urinary diversion are the following. Urine is kept inside the body until it is ready to be emptied. No collection bag is needed. Stoma is small and can be covered by a bandage. No activity restrictions. As for the disadvantages of an Indiana pouch, these are the following: longer surgery time than an ileal conduit, a higher complication rate, longer recovery period, and the need to use a catheter at scheduled times throughout the day, passing a small thin catheter through the stoma into the pouch every 4 to 6 hours to empty the pouch. As for the pre-operative assessment, the following are key pre-operative nursing assessment concerns. Cardiopulmonary function assessments are performed because patients undergoing cystectomy are often older adults who may be at greater risk for cardiac and respiratory complications. A nutritional status assessment is important because of possible poor nutritional intake related to underlying health problems. Learning needs are assessed in consultation with a WOC nurse to evaluate the patient's and the family's understanding of the procedures, as well as the changes in the physical structure and function that result from the surgery. The patient's self-concept and self-esteem are assessed in addition to methods for coping with stress and loss. The patient's mental status, manual dexterity and coordination, vision, and preferred method of learning are noted because they affect post-operative self-care. As for the preoperative nursing goal and interventions, the major goals for the patient may include relief of anxiety, improved preoperative nutritional status, and increased knowledge about the surgical procedure, expected outcomes, and post-operative care. As for the possible nursing diagnosis, based on the assessment data, preoperative nursing diagnosis may include the following: anxiety related to anticipated losses associated with the surgical procedure. Next is imbalanced nutrition, less than body requirements, related to inadequate nutritional intake. And last is deficient knowledge about the surgical procedure and post-operative care. As for the nursing interventions, first is relieving anxiety. The threat of cancer and removal of the bladder create anxiety related to the changes in body image. Patients may face problems adapting to an external appliance, a stoma, a surgical incision, and altered toileting habits. Next is ensuring adequate nutrition. A low residue diet is prescribed to cleanse the bowel, to minimize fecal stasis, decompress the bowel, and minimize post-operative ileus. In addition, antibiotic medications are given to reduce pathogenic flora in the bowel and to reduce the risk of infection. Because the patient undergoing a urinary diversion procedure for cancer may be severely malnourished due to the tumor, previous treatments, and anorexia, enteral or parenteral nutrition may be prescribed to promote healing. Adequate preoperative hydration is imperative to ensure urine flow during surgery and to prevent hypovolemia during the prolonged surgical procedure. Next is explaining surgery and its effects. Participation of a WOC nurse in patient education and care is invaluable for informed preoperative education and post-operative planning. Expectations of the surgical procedure, the appearance of the stoma, the rationale for preoperative bowel preparation, the reasons for wearing a collection device, and the anticipated effects of the surgery on sexual functioning are part of patient education. And next is for the post-operative assessment. The role of the nurse in the immediate post-operative period is to prevent complications and to assess the patient carefully for any signs and symptoms of complications. The catheters and any drainage devices are monitored closely. Urine volume, patency of the drainage system, and the color of the drainage are assessed. A sudden decrease in urine volume or increase in drainage is reported promptly to the primary provider, because this may indicate obstruction of the urinary tract, inadequate blood volume, or bleeding. In addition, the patient's need for pain control is assessed regularly, as with all post-operative patients. So for the post-operative nursing goal and intervention, the major goals of the for the patient may include maintaining skin integrity, relieving pain, increasing self-esteem, developing appropriate coping mechanisms to accept and deal with altered urinary function and sexuality, increasing knowledge about management of urinary function, and preventing potential complications. As for the nursing diagnosis, based on the assessment data, major post-operative nursing diagnosis may include the following. First is risk for impaired skin integrity related to problems in managing the urine collection appliance. Next is acute pain related to surgical incision. Next is disturbed body image related to urinary diversion. Next is ineffective sexuality pattern related to structural and physiologic alterations. And lastly is deficient knowledge about management of urinary function. For the collaborative problems or potential complications, this may include the following: peritonitis due to disruption of anastomosis, stoma ischemia and necrosis due to compromised blood supply to stoma, and stoma retraction and separation of mucocutaneous border due to tension or trauma. So for the nursing interventions for post-operative management, it focuses on monitoring urinary function, preventing post-operative complications such as infection and sepsis, respiratory complications, fluid and electrolyte imbalances, fistula formation, and urine leakage, and promoting patient comfort. Catheters or drainage systems are monitored and urine output is monitored carefully. A nasogastric tube is inserted during surgery to decompress the GI tract and to relieve pressure on the intestinal anastomosis. It is usually kept in place for several days after surgery, as soon as bowel function resumes. As indicated by bowel sounds, the passage of flatus, and a soft abdomen, oral fluids are permitted. Until the time IV fluids and electrolytes are given, the patient is assisted to ambulate as soon as possible to prevent complications of immobility. For patients with Indiana pouches, a Medina catheter will remain in place to drain urine continuously. This catheter may be irrigated with normal saline to wash out any clots or mucus that may accumulate, preventing drainage. The Medina catheter will be removed 3 to 4 weeks following surgery. Patients with Indiana pouches are instructed on how to self-catheterize and empty the pouch. Patients will develop their own routines, eventually self-catheterizing every 4 to 6 hours, depending on the volume of urine and that they can tolerate, and the sensation associated with the filling of the neobladder. It is essential that patients continue to be monitored by healthcare professionals at 3 months, 6 months, and have yearly appointments with blood testing, renal function tests, urine cultures, x-rays, and either ultrasound or photograph. The video that will be played next is for the visualization of the procedure, and next is for the catheterization for Indiana pouch to drain the urine.